Welcome. We're so excited today to welcome you to the first Stop Suicide QI Collaborative Fireside Chat, which will be focused on ensuring a safe ED environment. Next. We'd like to acknowledge that the EMSC for Children Innovation and Improvement Center, which includes the collaborative and this fireside chat, is supported by HRSA. And the contents are those of the authors and do not represent the official views of, nor an endorsement by HRSA, HHS, or the US government. Next. Just a few reminders. Thank you so much for joining. We're very excited to have all of you here with us today. Please remain on mute for the presentation. This fireside chat is being recorded and will be posted online along with the slides. Please feel free to put your questions in chat as they occur to you, and we will monitor the chat box and bring forward the questions during the discussion period. Discussion will follow the presentation, and then please, before you leave, complete the evaluation poll. Next, I'd like to turn it over to Mo.
Hi, everybody. Thank you again for joining us. It's a great honor to be here. Today, we're going to have a fireside chat with Dr. Jennifer Hoffmann in one of our 4 collaborative bundles. This specific bundle today is the ED-based intervention, and the bundle specific aim for this is that 100% of the sites will have established a clinical care pathway for children who screen high risk for suicidality. Next. So we have 4 quality improvement measures that are built into this intervention bundle. The first measure is the presence of a clinical pathway for pediatric patients that are already screened and noted to be a high risk for suicidality. This includes recommendation for diagnostic testing, strategies for de-escalation, restraints, whether it's medical, chemical, or physical restraints, as well as considerations for patient and family, especially when patients are boarding in the ED for a prolonged period of time. Measure 2 is presence of a standardized order set for clinical management of children who screen high risk for suicide, and ideally, if this is integrated into their electronic health record, but at least having that standardized order set to follow. Measure 3 is presence of a quality review process to evaluate how much engagement with the order set and how much utilization of that order set among children who screen high risk for suicide. And finally, measure 4 is the percentage of pediatric high-risk suicide cases that have had that order set compliance with. Next. So for this, it is my honor to welcome not only a good friend and collaborator, but an awesome person in the field of pediatric mental health. Her name is Dr. Jennifer Hoffmann. She is assistant professor of pediatrics at the Northwestern University and also a pediatric emergency medicine faculty at Lurie Children's of Chicago. Her research focus is on rising use of the ED by children for mental health reasons, disparities in care, ED-based quality improvement initiatives for agitation management and suicide prevention. She's also a member of the American Academy of Pediatrics Committee on Pediatric Emergency Medicine, where she contributes greatly to national policy statements related to mental health care. It is my honor to have Dr. Jennifer Hoffmann do today's fireside chat presentation. I'll hand it over to Jennifer.
Thank you so much for having me here today. You can go to the next slide. So the goal of this fireside chat today is to talk about ensuring a safe ED environment. So really the concept is to start by first doing no harm and making sure that all children who present for mental health reasons are safe in your ED. And I understand there's a very wide variety of EDs participating in this collaborative. So some of you may already have some of these processes in place. Others may be interested in focusing on these areas as part of your improvement for participating in this collaborative. So today I'm going to review triage considerations, how to ensure a safe room environment, medical evaluation, as well as de-escalation and acute agitation management, which can occur among children who are identified to be at high risk for suicide. And as you listen to this talk, I'll be speaking for about half an hour. Keep in mind and start to think about any items that you might want to integrate into a clinical care pathway in your ED or into an order set. And then we'll have about 15 minutes at the end to take any questions you may have. Next slide. So to start with triage, many of you may be using the ESI or the Emergency Severity Index from 1 to 5 in your EDs. In my experience, this scale is not particularly useful for triaging children who present for mental or behavioral health reasons. Many times, these children are given a score of 2, kind of regardless of the potential imminent safety threat, risk of elopement. And so you may consider using alternate strategies for triage. There's fairly limited evidence in this area to guide use of alternate triage scales, but one that I've come across that I find to be very practical is the Australian mental health triage tool that's listed on the right. And so the full tool is listed on their website, which you can find by a quick search of the title. But here's a brief summary. And this, in your ED, you might integrate this following the standard ESI triage level. Level 1 on the Australian triage tool scale is that the patient poses an immediate threat. They may be wielding a weapon and actively trying to harm ED staff. Number 2 are those patients who arrive already in physical restraints from the pre-hospital setting, or who have very severe agitation, aggression, or hallucinations that presents an imminent risk to the patient or others. Number 3 would include patients with mild to moderate agitation, who have active suicidal ideation, or who have some degree of paranoid or disordered thinking. Level 4 are patients who have isolated anxiety, isolated depression without associated suicidal ideation, and no agitation. And then finally, level 5 are patients presenting with chronic symptoms, requests for medication refills, or social concerns. So including a scale like this might help you decide who's safe to wait in the waiting room and who needs to be immediately roomed, as well as the appropriate level of observation. Next slide. So the next step in ED care is to ensure that the patient is placed in a safe room environment. You may consider choosing rooms that are in the direct line of sight of nursing and ED staff. And it's also important to ensure that the room is prepared to ensure safety before the patient arrives. You can see in this picture, this is a room that's been fitted with a garage door that comes down to prevent patients from accessing equipment on the wall. But this type of device may not be available in all EDs. Nevertheless, there are strategies to ensure that standard medical rooms are safer as much as possible. And one such strategy is using a room safety checklist, with an example here on the right that you can find in the New England Regional Behavioral Health Toolkit that's part of the EIIC website. So this kind of checklist ensures that all dangerous objects are removed, including items in the sharps container, IV poles, other medical equipment. And I think this is quite important to have a standardized process to do so. Other considerations when the patient is initially roomed are to change them into a hospital gown whenever possible, because the patient's clothing may present a safety risk, particularly if any of the clothing includes strings like ties of a hoodie, bras, even wires in patient masks. Now that all patients are masked in the era of COVID, those wires ideally should be removed from the mask that's given to the patient. Of course, you should remove any shoes or belts, as these could be potentially used as weapons, and ideally would change them into a gown. It's also generally recommended to remove the patient's phone from their person because their phone could be used as a method to communicate with others outside the ED environment, such as peers who might assist the patient in eloping from the ED or bringing them weapons to the ED. Belongings that are brought on the person of parents, guardians, or visitors should also be searched to ensure there aren't any unsafe objects. And you might also want to consider that sometimes visitors come midway through an ED stay and bring new items into the room. So one way to handle that is to do room safety checklists repeatedly, maybe on an every shift basis, to ensure that no unsafe items have been brought. Or some EDs will actually ask visitors to place all of their belongings in a locker before they make their way to the room. Next slide. So the major focus of this collaborative is around suicide screening and risk assessment, and you'll hear much more about this in the upcoming Fireside chats. But just as a very brief introduction, some of the decision points are whether to do suicide screening out in triage or after the patient is roomed. These are two examples on the screen of validated screening questionnaires. The one on the left is the ASQ, or the Ask Suicide Screening Questions, and the one on the right is the CSSRS, or the Columbia Suicide Screening Questions. It is important to use validated tools because these have been designed so that the exact wording of questions is best to detect suicide risk. In addition to deciding where to screen, you also might start to think about who's the right person to screen in your ED. Is it the triage nurse? Is it the physician after rooming? And also how to screen. Are you going to ask these questions verbally? Are you going to ask them in front of the parents, or ideally ask the parents to step away temporarily to promote privacy? Or some EDs have actually adapted these onto iPads or laminated sheets where the child can answer the questions in a written or electronic format, which may allow for some degree of privacy, even if the parents are present. And so again, just think about the right step in your process for where to integrate these kinds of tools, and you'll hear much more about them later. Next slide. So once the patient is safely roomed and at some point they've received their initial suicide screening as part of intake, then there'll be a more thorough history and physical taken. So one tool that is evidence-based in order to take a detailed psychosocial history for a child presenting with mental or behavioral health reason is the HEADS ED questionnaire. And this is a way to kind of gain rapport with the child by starting with easier questions about the child's home, education, the activities they participate in, and then leading into more sensitive questions around drug and alcohol use. Repeating questioning about suicidality here after a rapport has been established, and then asking about emotions, as well as the D is for discharge or current resources, which may occur later in the process. But this can be scored on a scale of 0 to 2 for each item, based on how well the child is doing or how much attention is needed to each of these domains. Just as a note, before you start getting into this type of questioning with a child, it is important to establish the limits of confidentiality. So sharing with the patient upfront that any information they disclose about potential harm to themselves or others may be an indication to break confidentiality, and that you may not be able to keep that private from their parents or other healthcare providers. It's also helpful sometimes to start by interviewing the child and parent together before then asking the parent or guardian to step out of the room and interviewing them separately. And any child who does express any suicidality should go on to receive additional suicide risk assessment, which will be covered in much more detail in other Fireside chats. Next slide. So next, you'd want to do a medical evaluation, and that's to ensure that there are no concurrent medical or physical health issues, and also no contributing medical issues that may be leading to the presentation of depression or agitation. And particular attention should be made to evaluating for any signs of drug withdrawal, intoxication, or overdose, any signs of adverse medication effects, such as serotonin syndrome or neuroleptic malignant syndrome, evidence of thyroid disease based on symptoms or physical exam. A full skin exam is recommended, which is another reason to change a patient into a gown, to look for any ligature marks around the neck, any self-inflicted wounds, particularly on the forearms or the thighs, as these may require suturing if they're deep, cleaning, or tetanus boosters. And then also on that full skin exam, to look for any bruising or other marks that may be suggestive of physical or sexual abuse that should also be addressed during that visit. Particularly for children who are nonverbal or developmentally delayed, looking for any sources of pain that could cause agitation is important at this step, such as assessing whether the child may have an ear infection, constipation, evidence on history of a UTI, or on physical exam of a rash. So these are some of the common considerations as you're performing a medical evaluation. Next slide. So the American Academy of Pediatrics section on emergency medicine recently came out with a Choosing Wisely campaign just a few months ago with 5 items that are low value care and that should be avoided. And item 2 on the Choosing Wisely campaign states, do not obtain screening laboratory tests in the medical clearance process of pediatric patients who require inpatient psychiatric admission unless clinically indicated. So there has been a large, robust body of evidence to show that routine panels of screening labs are very low yield, and these are no longer recommended in the medical clearance process. And in fact, we're moving away from the terminology medical clearance to just use the term medical evaluation. Next slide. So here's just 2 studies, they're exemplar studies that show the evidence for not obtaining screening labs among all children presenting for mental and behavioral health reasons. This study looked at over 1,000 children under 18 years old who were on an involuntary hold. In this study, that meant that they were awaiting admission for psychiatric care. And of those that had a non-contributory history and physical without identified medical problems on the history and physical, there were 25 patients who had non-urgent management changes made based on the results of laboratory tests. And examples included detecting iron deficiency anemia, for which the patient was started on iron, mildly abnormal thyroid tests that then were normal upon repeat testing later on in the outpatient setting, or mild dehydration that was treated either with an IV fluid bolus or oral rehydration. There was only 1 patient in this study that had a disposition changing result that was unexpected, and that was a positive urine pregnancy test. Overall, the cost of testing was over $1,000 per patient, and the authors extrapolated this to the national scale and estimated that the healthcare system could save $90 million if routine lab testing of pediatric psychiatric patients was eliminated on the national scale. So in practice, in my ED, and what I recommend is obtaining a urine pregnancy test on all post-pubertal females. And now these studies were done before COVID-19. It may be prudent for patients who are going to be admitted to a setting that involves cohorting a large number of children together for therapy to obtain a COVID-19 test. And that's more to prevent outbreaks in the inpatient psychiatric units or other care settings. Additionally, you may consider obtaining urine drug screen testing if you think it will change where you will refer the patient in your local area. So in some areas, there are facilities that are particularly well equipped to managing concurrent substance use treatment. And if you have one of those facilities in your area, and obtaining that drug screen result to identify substance use would change where the patient is placed, that may be a consideration to routinely obtain that in your ED. Another note is that in these studies here, the majority of patients were presenting with depression, suicidal thoughts or attempts, or agitation and aggression. Only 3% of the children in these studies were presenting with acute psychosis. And there are, in general, more medical and physical health etiologies that can lead to acute psychosis. So my personal recommendation is still to obtain laboratory testing for children presenting with acute psychosis to look for things such as, a new presentation of lupus where there's psychosis associated. You can see that on laboratory testing. You can get those LFTs to look for rare things like Wilson disease. So I would say that I would put a carve out for patients with acute psychosis and still consider lab testing for those children. Next slide. So now that the medical evaluation is completed, the next step I would recommend is providing safe activities for distraction while the child is waiting in the room. And here you can see some examples of items that may be helpful. I like to think of them divided based on the child's age group, their developmental level, as well as if they have associated autism spectrum disorder or other sensory sensitivities. So here on this slide from left to right, you can see some examples that are particularly helpful for children with autism or sensory sensitivities. The first is a fidget spinner. The second is a rain stick, which makes soothing noises as it's turned. The middle are sensory balls, which have different textures, chewy tubes that patients can bite on, and then fidget poppet toys on the upper right. And you can see listed on the bottom some other items divided by patient age group. This really could be as simple as remembering to turn on the TV for every patient as you leave the room if you don't have any of these items in your ED, or asking the patient what would help them stay calm while they're waiting. One good resource to look at is the New England Regional Behavioral Health Toolkit that will be shared with you. They have a purchasing guide that recommends low-cost items that can be purchased, as well as an activities binder that includes self-directed activities for teens, such as deep breathing, meditation exercises, coloring, and puzzles. Next step. So this also is a good time to do some communication with the family and set expectations about the visit. This can be done verbally, or in our ED, we actually have a printed handout that we pass out to each family that describes the process of what a mental health visit will look like, what they're waiting for, what can be accomplished and what can't be accomplished during an ED visit. And some questions that you might consider asking at this stage are, what works best for your child while they're waiting in the ED? What tends to trigger your child? Is it being touched? Is it loud noises, bright lights, too many people in the room? What helps calm them down? And what are their baseline behaviors, particularly for children who have developmental delays? Next slide. And you may even consider developing personalized care plans. We've found that these are very helpful for children who have autism spectrum disorder, other sensory sensitivities, or have a prior history of agitation or aggression. The example on the left shows how we've embedded them into our electronic health record at Lurie Children's. They carry forward across encounters, and they're visible in a bright yellow banner in the patient's chart underneath their name. And when clicking on these guidelines, they open up, and patient-specific strategies for de-escalation and to help them tolerate boarding in the ED can be checked off. In our ED, this is completed by our mental health consultant, which is a social worker by training, but this could also be done by a nurse or even by the sitter if they have appropriate training. On the right, you can see an example of this done on paper instead of embedded into the electronic health record. This one is from Rady Children's, and it just goes through how best to communicate with the child, what their interests are, what makes them upset, and specific strategies that help keep them calm while in the emergency department. Next slide. So this is a table that is available through the PEAK toolkit. PEAK stands for Pediatric Education and Advocacy Kit. And this is an amazing toolkit put together by EIIC that includes a whole host of resources for learning about agitation management and de-escalation, ranging from podcasts to handouts. And this is one of the handouts that's available that shows a whole variety of de-escalation strategies that can be implemented. In our ED, we placed a table like this on page 2 of our clinical care guideline. And this just allows for easy reference to these strategies by our staff. And they're divided into managing the environment, behavioral de-escalation, and calming interventions. And they include pieces that we've mentioned around removing dangerous objects, maintaining a safe space, dimming lights, minimizing noise. And then in the middle column, making sure to listen to the patient and caregiver, using a neutral tone and body language. Offering choices is a very important strategy. Things like, would you like to watch TV or would you like to draw? Even if the patient is becoming more escalated, using choices such as, would you prefer to take a medication by mouth or a shot, and seeing which one they choose, and of course, rewarding cooperation. On the right, you can see some calming interventions, which include safe activities, food, detailing next steps, and then debriefing after any episodes of agitation. Next step. So it is important to take a team approach to agitation management whenever it does occur, acknowledging that this occurs in a minority of visits for patients presenting with suicide risk. But certainly these patients are at higher risk than other patients who present to the ED. So if an episode of severe acute agitation occurs, there should be a team lead designated who can direct overall management, including role assignment and crowd control. I'd recommend assigning one individual to be at the patient's bedside who is directly communicating with the patient and leading the verbal de-escalation strategies. This is often a bedside nurse or a sitter if you have those available. An ordering provider should be assigned who can help pull up the patient's records, see if they have any care plan or any medications that have worked for them well in the past, and who can order medications if they're indicated. Nonverbal de-escalation should continue throughout, even if the episode of agitation is severe. It's also helpful to assign a nurse to draw up and administer any medications that are needed. Ideally, they would bring both oral and intramuscular medications to the bedside, offering the patient the oral medication first, if at all possible. And orally dissolving formulations such as olanzapine can be particularly helpful to aid in administration and cooperation. It's also important to consider the etiology of agitation, and if there is an addressable underlying medical condition, that of course should be treated first whenever possible. The choice of medication may also be guided by the etiology. For example, in patients with suspected ingestions, you may not want to give a medication that would further prolong the QT interval, such as an antipsychotic medication, and benzodiazepines might be preferred instead. Some hospitals have begun to organize behavioral response teams, which are a type of response similar to how you might call a code for an acute medical situation. You can activate a behavioral response for episodes of severe acute agitation. And these teams tend to bring personnel immediately to the bedside, ideally personnel who are trained in verbal de-escalation. At our hospital at Lurie Children's, this includes either a social worker, a milieu therapist, or a psychiatric nurse who comes down from our inpatient unit. I acknowledge that is likely not available in many facilities, but at a minimum, this type of response could bring the right players to the bedside quicker when agitation is at an earlier stage, so that maybe it can be treated with oral medications instead of needing to resort to IM medications or physical restraints. So it is something to consider that's actively being studied to see whether it improves management. Next slide. Also, you can consider developing or including an agitation algorithm as part of your clinical care guideline in your ED. An amazing example of an agitation algorithm has been put together by EIIC and TREC. TREC is a Canadian organization that stands for Translating Emergency Knowledge for Kids. And this is available through the PEAK toolkit on the EIIC website, and we'll make sure that you have a link to it. But this type of algorithm ensures there's a standardized approach for every episode of acute agitation. And it includes some of those components of role assignment, assessing for the medical etiology, and making sure that all possible de-escalation strategies are used, as well as personalized care plans if you decide to implement those. The middle section provides recommendations on medications that include weight-based dosing strategies. And then, of course, after an episode occurs, monitoring for any side effects of medications that have been given, and debriefing and coming up with a plan to prevent re-escalation. Next slide. So the medication choice should ideally be based on the level of agitation as well as the etiology. For mild agitation, verbal de-escalation, distraction are recommended. And if the patient has home medications, they can be given early or can be used in a PRN in some cases. For moderate agitation, I typically recommend either diphenhydramine or lorazepam. And for severe, I recommend olanzapine, ODT, or IM. There really are no high quality studies to suggest which medication is most effective or safe in children for severe agitation. So the rationale that I have for choosing olanzapine as a first-line medication is that it's second generation, which means it's less likely to cause dystonic reactions. There's also some simplicity in needing to draw up only one medication and administer one medication as opposed to a combination. And most importantly, because it's available in both orally dissolving and IM formulations, a choice can be given to the patient at the bedside. And in our experience, at least some of the time, they do choose the orally dissolving tablet, and that allows for avoidance of more restrictive interventions. Physical restraint really should be used as a last resort when needed for safety. Some other tips here at the bottom. It is recommended to wait a sufficient time for the medication to take effect. Many of these medications can take as much as 30 minutes to take effect. And if medications are redosed too quickly, dose stacking can occur along with oversedation. It may be nice to repeat the same medication as opposed to switching classes, again, because each medication has a different onset of action. And so if you're switching to many different medicines, those may all overlap with the same peak time of onset and lead to unintentional oversedation. Finally, olanzapine and lorazepam IM should not be given together within 1 hour due to some case reports of cardiopulmonary depression with that particular combination. Next slide. There are adverse effects of antipsychotics that are listed here that should be monitored for. The most common one is an acute dystonic reaction, which presents as twisting and posturing of the muscles, and that can be treated easily with diphenhydramine. Other ones to watch for include oversedation, orthostatic hypotension, QTC prolongation, neuroleptic malignant syndrome, and over the long term, tardive dyskinesia. With QTC prolongation, if multiple medications are given, if it's safe to do so, best practice is to obtain an EKG to monitor that QT interval. And that's because there is a risk for torsades if that does become too lengthened. Next slide. Physical restraints are a last resort. The patient should be positioned supine with the head of their bed slightly elevated, Pressure should not be applied to the neck, back, or chest, and the face, mouth, and nose should not be covered. There are regulatory requirements around physical restraint use, such as requirements for order renewal at certain frequencies by age, and particular regulatory requirements for documentation of face-to-face bedside assessments within particular timeframes. And you should be familiar with those in your local area. Restraints should be reevaluated and removed as soon as possible. Next slide. So to wrap up our section on ensuring a safe ED environment, it's very important to strive for equitable trauma-informed care throughout our care for children presenting with mental and behavioral health reasons. One study here that was conducted by my colleague Katie Nash at Yale at the time showed that ED visits by Black children have nearly twice the odds of physical restraint use compared with ED visits by white children. So it's important to keep in mind that patients who are at risk for agitation are often the same ones who faced multiple adverse life experiences, or ACEs, including prior involvement in child protective services, involvement in the criminal legal system, or having lived in lower opportunity neighborhoods. Also, these patients may have had prior negative experiences with the healthcare system that may lower their trust in healthcare providers. So every episode matters in terms of being able to build a more trusting relationship. Using standardized care pathways, such as some that you may be creating as part of this quality collaborative, is one strategy to ensure that the care we provide is standardized across all segments of and groups of children. Having standardized pathways can promote objective criteria for assessment. And another strategy to consider is simulation training to practice and reinforce a standardized approach. Behavioral response teams, which I mentioned earlier, are another way to ensure that highly trained staff reach the bedside quickly. And then finally, as you consider and embark on this quality improvement initiative, you might consider stratifying your data by patient race and ethnicity to make sure that any kind of initiatives that you're taking are applied equally across racial and ethnic groups, across payer groups, across children who have different language proficiencies. Next slide. So the take-home points for this first fireside chat are first, do no harm. So all EDs should have policies in place to ensure a safe ED environment for children with mental and behavioral health conditions. In terms of the medical evaluation piece, do not obtain screening blood work on all children unless clinically indicated by the history and physical. Although if the patient is being admitted, you may want to consider a COVID-19 swab, HCG, or drug screen if indicated based on your local environment. And for acute psychosis, you may consider a broader workup. Overall, it's important to take a patient-centered and trauma-informed approach, and you may consider incorporating some of these steps into your guidelines or order sets. Next slide. Here are some resources that I recommend that you might consider using as you embark on your QI initiatives. The Pediatrics AAP clinical report on evaluating and managing children with mental health conditions in the ED. Project Beta was developed as it's a consensus guideline by child psychiatrists on how to best manage acute agitation. The HRSA Critical Crossroads Toolkit is great for looking at different screening tools that you might consider implementing. The NIH ASQ Toolkit is an example of one particular suicide screening questionnaire. The 988 Suicide and Crisis Lifeline is a new national 3-digit dialing code that went live last July. That is an awesome resource for discharge that allows patients to have access to a hotline at any time. And there's also an associated text line. The New England Regional Behavioral Health Toolkit I briefly mentioned, in that it has the room safety checklist and the ordering guide for activities, but you'll hear later from Dr. Joyce Lee and Dr. Ashley Foster about all of the many components in this toolkit that's really geared for non-children's hospital and low resource EDs. the AAP Suicide Blueprint for Suicide Prevention, and the PEAK education and advocacy kits that provide educational materials around both agitation and suicide. So next slide. That's all I have prepared for you today, and I'll turn it back to Laura.
Thank you, Dr. Hoffman. That was an exceptional presentation, and we're very grateful for your time and all of the work that you do on behalf of kids and adolescents. I don't see questions in the chat, so I would encourage anyone with a question to please go ahead and put that question in there. And while you're thinking about what your question might be, I wanted to mention that I'm aware that some of you may be wondering how you support. Okay, thank you. You may be wondering how you will support your team to make a decision about which QI project or improvement process to work on. And my suggestion would be that you use your environmental scan results, as well as consider your existing resources at your site to focus that, because we want you to be successful in bringing about change. Even a small change in clinical care process related to pediatric acute suicidality can make a big difference, not only for patient outcomes, but also for the way that you feel about the work that you do every day. So I'm going to turn it over to Mo Saidinejad to talk about some questions.
Yeah, thank you so much, Laura. And thank you, Jennifer, for an amazing presentation as usual. I just wanted to also kind of reiterate what Jennifer said about the body of work that we have at the EMS for Children Innovation and Improvement Center, the specific Pediatric Education and Advocacy Kit, or the PEAKs. I put the 2 links in the chat for you. We have a PEAK specific to suicide and has some amazing types of information in there. For example, there's an ABCD of suicide kind of infographic card, which was designed by Dr. Joan Asarno, who is a SAMHSA-funded researcher, has a PCORI on suicidal youth, and she has this as part of her program. Also, there are 3 podcasts in there, and one of the podcasts is with Dr. Lisa Horowitz from the National Institute for Mental Health. She's actually one of the developers of the ASQ tool. And she goes, it's a very kind of 5 to 6 minute podcast. She goes over what is the intended use of the ASQ tool and how you're supposed to kind of interpret the information. There's also a podcast on what to do with a child who is already screened positive on one of these validated tools. As Jennifer was saying, you'd really want to use a standardized validated tool to do the screening if that is part of what you do. And so that podcast with Dr. Joan Asarno also goes over kind of things that you do in the ED-based interventions that are suggested. And she's a clinical psychologist, so she gives it to you from the psychologist's perspective. And then finally, a third one is a work of PCAR, and the CASI tool is an interview with Dr. Jackie Grubb-Felin. Also from the agitation standpoint, we have a great deal of information in there, including the evidence synthesized by our team at Baylor, a medication table, very similar to what Jennifer presented. And again, the rationale for using medications like olanzapine first, because a lot of hospitals, especially community EDs, either don't have access to it or it's too expensive. They use old-fashioned things like promethazine. So it's good to have a sense of best practices. So all of those things are in there for you. Some of them are longer. There's also educational modules that we're planning to publish soon on both suicide and agitation, and we'll update you when those become available. So that kind of goes into a little bit more detail. So on that note, I have a couple of questions, Jennifer, I was going to ask you that might be helpful to everybody in this session. And let me see if there's a... Hold on one second. Let me see what's going on here. Okay, so I'm getting a message that there are 3 questions already in there. Laura, I don't see the questions. Do you have them? You want to, because I'd rather get your questions first before I ask mine.
I can see one.
Okay, can you ask that?
Yes, hold on 2 seconds. I would like to ask, what are calming techniques, resources, activities that are recommended for the aggressive autistic teenagers? Trying to calm these children can be a challenge, and will the patient intake form for parents to complete be available for us to use?
Yeah, so there's an example of a personalized care plan within the New England Regional Behavioral Health Toolkit that Dr. Joyce Lee and Dr. Ashley Foster will go through during a future fireside chat. And that is I believe it's editable, so you can adjust it for your own environment. This is a particularly challenging population that's at very high risk for acute agitation. And many of us see children with autism spectrum disorder having recurrent visits to the ED for difficult to control behaviors. I think that completing a personalized care plan is probably the best first step to try to help with managing these children, because many of them have specific triggers or specific de-escalation strategies that work well for them, that are very helpful for ED staff to learn, whether it's that they love watching videos of Peppa Pig, or they really enjoy rain sticks, or they need to be chewing on a chewy tube in order to prevent biting staff. And if it's too much of a lift to involve a personalized plan in your electronic record or on paper, simply building in a question that asks parents upon the child's arrival, perhaps during triage, what works best for your child? Do they have a prior history of agitation or aggression? And in those cases, what worked best? So just that simple question before agitation occurs can provide so much rich information, because parents and caregivers do know these children best, better than any ED staff could. Other specific de-escalation strategies that really are targeted for children with autism spectrum disorder include specific communication devices. Some children use pictorial communication boards or respond well to storyboarding, which is when there is a visual of what's going to happen during the ED visit, maybe showing visually first changing into a gown, then providing a urine sample, then getting your heart listened to. And so if you're able to incorporate a storyboard at triage, even you could pass it out to the parent and they could go through it with their child. That's one specific strategy for children with autism spectrum disorder. And the other one that really is very specific for this group are some of these sensory tools that I showed on one of the slides that involve limiting noise and limiting light. So providing headphones, dimming the lights or putting them in a quiet corner, minimizing the number of staff in the room, using clear, simple directions that only have one step at a time. So those are a couple of strategies that come to mind.
Thank you so much, Jennifer. Also, I wanted to add that we do, on our peak for agitation, we have a podcast, I forgot to mention this, with Dr. Alice Kuo, who's an expert in this field. Is a podcast done with Dr. Eileen Claudius, and Eileen Claudius is a big podcaster known very well in the adult ED world with MRAP. I just put the link for that in the chat as well, and this was actually repurposed to be part of Brad Sobolewski's PEM blogs, so it's under his channel as well. We also have an audio podcast version of that. Alice goes exactly through all of those things, Jennifer, that you also mentioned, because she has a HRSA-funded clinic just dealing with that agitation in she called it neurodivergent children. So that's another resource for you guys to look at. So I see another question in here. It's from Kirsten. The question is, are the individualized coping plans completed on all patients less than 18 presenting with suicidal ideation or self-inflicted harm, or only those with coexisting developmental delays or sensory processing disorders?
That's a great question. Ideally, this would be completed on any patient who's at risk for developing agitation in the ED. However, currently there are no evidence-based tools to identify the group of children at risk for developing agitation in the ED, something I'm working on the research side. So at this time, there's sort of two options. One is to do a plan for every child presenting with a mental or behavioral health complaint. The other option is to rely on clinical judgment. If the child has had prior episodes of agitation, if they have autism spectrum disorder or other developmental delays. In our ED at Lurie, we're currently completing them based on clinical judgment of the psychiatric social worker who performs our mental health evaluations. And we're completing them on about 30% of patients. So I think there is probably a targeted group where this is most helpful. There just aren't well-established tools to identify that group yet.
Awesome, thank you. And I think that you already answered, there was a question from Malia Silva, who asked about calming techniques, resources, activities that are recommended for aggressive autistic children. Trying to calm these children can be a challenge, and will the patient intake form for parents to complete be available for us to use?
Yeah, I think I covered that one.
Yeah, and then let's see, another part of what Kirsten had asked was it also appears your healthcare system utilizes Epic base. On the screenshot, is the build you all use available for use in other healthcare systems?
That's a great question. If I can find out, feel free to email me to follow up if there's a way to share that through Epic so that the coding doesn't have to be done again from scratch. I know there's many different versions of Epic, so things that are built in one system may not always translate to another. They're related to suicide, though. I do know that Epic has a standardized safety plan for discharge, a module that's based on the Stanley Brown safety plan, which is the most evidence-based safety plan. And that's something that exists in the Epic world that you can choose to implement in your own ED. So that one for sure I know is available.
And then there's somewhat of a controversial question here, because we don't want to recommend a specific screening tool, but we also wanted to ask, do you think the ASQ questionnaire is better than the CSSRS screening tool, or should hospitals use both tools?
Yeah, I mean, in my own clinical experience, I've worked in 2 EDs that have utilized the ASQ only. So I have less direct clinical experience with the Columbia. I think some of the nice aspects of the ASQ are that it's short. So every patient is only asked 4 questions. And if they're positive on one of the first 4, they're asked a 5th question. So it's very feasible to do. There's a robust evidence base around the ASQ being feasible. And some studies have shown that 80% or more of children presenting can be screened in the real world setting outside of research studies. And then there is a nice follow-up risk assessment that occurs called the BSSA, or the Brief Suicide Safety Assessment. That is a structured worksheet that follows children who screen positive on the initial 4 to 5 questions. So my own personal experience has been with the ASQ, and I find that it's short, it's feasible, it's quick. There's a well-established follow-up step for children who screen positive. And there will be many other experts coming on that are familiar with the variety of screening tools in a subsequent Fireside chat.
Excellent. And just one quick last question. You had mentioned about the labs, and we on the policy front of AAP, we get into the details of who needs lab testing or not. Is it fair to say that if you do a medical screening exam and there isn't anything medical and you just dealing strictly with a psychiatric illness, that's when you just say no labs are necessary? But if the patient cannot be medically cleared, then you do the lab screening based on what it needs, such as like psychosis having an organic cause or something like that. Then you do labs appropriate for what requires you to get the patient medically cleared.
That's correct. So the laboratory testing should be based on the history and physical. If a patient presents with a suspected overdose or ingestion, then it would be appropriate to order Tylenol, ethanol, salicylates, those sorts of labs. If the patient has acute psychosis, that's one of those carve-out exceptions where Very few children present with that, and there are more potential medical etiologies. So I do think blood work is indicated in that circumstance. I'm working on a multi-center study through the PEMCRC network to answer that question more definitively for you. But most children who are presenting for isolated depression, isolated suicidal thoughts, or isolated aggressive behaviors who have a normal physical exam should not have routine laboratory testing sent. There are external factors outside of some folks' health systems where they may not be familiar with the latest evidence, and that's where you can use these new PEM Choosing Wisely campaign guidelines as a resource for advocacy. I know of one children's hospital on the East Coast that recently was able to change the policy at their inpatient psychiatric unit, where previously they were requiring screening labs, and using through the evidence and the fact that AAP no longer recommends routine labs, they were able to change their policy. So that's another potential opportunity for QI, particularly if it's within your own health system.
Yeah, and you say the same thing for those who require testing for illicit drugs, even though it's not going to change your management, just because I want to know if this person has been doing certain drugs, that is also not something that we would want to routinely recommend.
Right. If it's going to change your referral pattern so that you would then send them to a center that focuses on substance use, you may consider it, but it's not something that has to universally be done.
Excellent. Thank you again so much, Jennifer. Really, really appreciate this. I hope this was as informative to you guys as it was to me. And I'll pass it on back to Laura for closing. And again, thank you so much, Jennifer, for your time and for this talk.
Thank you both. I also wanted to thank our planning team and advisory committee members for all of the efforts that went into planning this collaborative. Please stay to complete the evaluation. And two more minor things. We will have additional resources and tools linked into the bundle guides, which we hope to provide to you as soon as possible. Thank you for coming today. We can go ahead and launch the evaluation poll.